Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, Dr. Alwi and to the friends. So today we are going to have our neurology seminar. So this seminar, we have 5 presenters. First is going to talk about meningitis and encephalitis, followed by febrile seizure, childhood epilepsy, muscular dystrophy, and lastly, cerebral palsy. So proceed to the first slide. Meningitis and encephalitis by me, Nur Aman Balkis binti Asmai. So these are what I am going to talk about. First, I am going to talk on meningitis. After that, we are going to cover encephalitis a little bit. Okay, so meningitis, from the name itself, we know that itis means inflammation. So it is inflammation of the meninges. And we know that we have 3 layers of meninges. Sorry. 3 layers of meninges: pia mater, arachnoid mater, and dura mater. So according to Nelson textbook, meningitis refers to inflammation of leptomeninges. So what is leptomeninges? In Greek, lepto means thin. So leptomeninges refers to the thin and delicate layer of meninges, which are pia mater and arachnoid mater. When the inflammation also involves dura mater, which is a tough layer of the meninges, it is called pachymeningitis. Okay. And incidence of meningitis is very high especially among children below 1 year of age, and it is potentially fatal. And what are the risk factors of getting meningitis? First, if the child is immunodeficient, either acquired or congenital, so this make them prone to infection. And also, if the children have asplenia. Asplenia means there is a loss of normal function of the spleen. We know that spleen is a part of the lymphatic system that helps to fight infection. So if someone has asplenia, they are at a very serious risk of getting infection. And also cochlear implantation, penetrating head trauma, recent neurosurgical procedure, and also crowding. So these are all risk factors that make someone prone to infection, and then infection can cause, and that kind of infection can cause meningitis. Okay. Before that, okay, and then next, what are the etiology of meningitis? We can divide the etiology into infectious causes and non-infectious causes. For infectious causes, it can be either viral, bacterial, fungal, or parasitic infection. For infectious causes, viral infection is the most common causes of meningitis. It is also known as aseptic meningitis. Meanwhile, for bacterial infection, although it is less common, but it is very severe, and there is a high rate of mortality, and the survivor suffer long-term neurological impairment. And for fungal and parasitic infection, it is rarely cause meningitis. Meanwhile, for non-infectious causes, it can be due to drugs or autoimmune diseases. For drug, I believe it is because hypersensitivity reaction, and then autoimmune disease, we know that it can cause inflammation as well. Okay, so these are the organisms that can cause meningitis. For bacteria, it is different according to age group. So, meanwhile, for virus, these are among the common virus that can cause meningitis. And as I said earlier, fungal and parasitic infection rarely cause meningitis, but it can cause meningitis, especially in immunodeficient children. So that's it for organisms that cause meningitis. So how do they actually cause inflammation at the meninges? First, there are 5 important mechanisms. First is colonization of mucous membrane. So these pathogens, they have a surface component that help them to attach themselves to the mucous membrane, such as fimbriae and villi, and they also able to secrete protease that inactivate mucosal antibodies. So that's how they colonize the mucous membrane. For example, at respiratory tract or gastrointestinal tract, and also lower genital tract. Okay, so after they colonize mucous membrane, they will try to invade the bloodstream. Sorry. So how do they go into the bloodstream? This is mediated by interaction of environmental factor, host factor, and also genetic factor of the pathogens. For environmental factor, for example, if the children has prior bacterial infection, and then meanwhile for host factor, as I mentioned earlier, if the child is immunodeficient due to aspirinea or complement deficiency or antibody deficiency or any immunosuppressive condition. And then after the virus colonize the mucous membrane, and then they go into the bloodstream, and they need to survive in the bloodstream. So how do they survive? They have polysaccharide capsule that prevent phagocytosis. Their polysaccharide capsule make it hard for our immune system to phagocytose them, so they survive. And they also have binding protein that targets specific complement components. So complement components cannot destroy them. So that's how they survive in the bloodstream. Okay, so after surviving in the bloodstream, they need to go to the meninges. So how they gain entry to subarachnoid space that contains CSF? Firstly, it may be through choroid plexus, and they also adhere to the brain endothelial cells. This facilitates the opening of interendothelial junction. So when the junction open, so they migrate into the CSF. Okay, so when they are in the CSF, finally, there is a generation of inflammatory cytokines. As bacteria enter CSF, there is a recognition of bacterial components. So this results in inflammatory response by the body. So the body tries to respond by recruiting leukocyte and generate an in situ generation of inflammatory cytokine. So this recruitment of leukocyte and generation of inflammatory cytokine can lead to increased intracranial pressure. Okay, so that's for the pathogenesis. Next is clinical presentation. So among the typical manifestation in meningitis, first is fever. Fever is because the body tried to increase the body temperature to make it less optimum for pathogens to survive. And then also the next one is stiff neck. Why is stiff neck? Because meninges cover brain and spinal cord, so it goes through neck and all the way to the back. So when patient with meningitis try to move their neck, it rasa macam sakit sikit, okay, macam pain, stiff neck, okay. And then opisthotonus is the arching of back. This is the picture. This happens because of muscle spasm. Sorry. Okay, and the next one is photophobia. So why a patient with meningitis experience photophobia? It is due to irritation of the meninges around the diaphragma saline. And they also showed symptoms of increased intracranial pressure, such as headache, nausea, vomiting, diplopia, and also bulging of fontanelle in infants, because their fontanelle is not yet closed. So because their fontanelle is not yet closed. And in young infants, it is actually hard to diagnose them because they showed non-specific symptoms. They cannot tell us that they have headache or stiff neck or etc. So Among the symptoms that we need to realize are poor feeding, vomiting, rash, respiratory symptoms, and irritability. Rash is usually associated with some specific pathogens such as rash is specific to a specific pathogen. I don't remember. Okay, and then in children more than 12 months old, we can access for Brudzinski sign and Kernick sign. So this is Kernick sign when the child is lying. When we flex the hip, okay guys. Oh, this is okay. Sorry, I tersalah. Okay, so this is Kernick sign. Kernick sign is when we try to straighten the knee, and then there is a resistance that the child cannot straighten the knee. And then this is Brudzinski sign. So Brudzinski sign is positive if we notice that there is a flexion of the hip when neck is flexed. Okay. So the next one is investigation. So what you can do to investigate to diagnose meningitis? First, we should do blood tests. So blood tests should include blood culture for any growth of bacteria or virus, and then full blood count, and also prothrombin time and partial thromboplastin time. This is especially done in patients with petechia or purpura, and also serum electrolyte, blood urea nitrogen, creatinine, and glucose. Apart from that, CSF studies should be done also by lumbar puncture. Okay, so lumbar puncture in viral encephalitis, after doing lumbar puncture, it may provide symptoms of relief. Okay, meanwhile, and what should we look in CSF? We should send it for cream stain and bacterial culture, cell count, glucose, and protein. So, so CSF findings are different in viral encephalitis and bacterial encephalitis. Okay, so the next one is virology. So virology, we can do is done by PCR analysis because the results are fast compared to doing culture of CSF. So we can do PCR to diagnose viral encephalitis. And stool, okay. Stool or rectal swab and throat swab can also be sent for viral culture to maximize detection. And serologies can also be done, especially for the less common etiologies, where we detect the antibodies that present towards any specific pathogen. And the last one is imaging. Okay, so imaging can be done before lumbar puncture, especially in patients with signs and symptoms of increased intracranial pressure. And this is important to assess brain inflammation and to make a distinction between encephalitis or meningitis. So the next one is complication of meningitis. We can divide complication into systemic and neurologic complication. Okay, so systemic complication are usually the consequences of bacteremia. They are like septic shock, the IBC, acute respiratory distress, and septic or reactive arthritis. Meanwhile, for neurologic complication, it includes cerebral edema due to increased fluid volume in the brain, and also seizure, and also hearing loss. Hearing loss is a result from the damage to the 8th cranial nerve, cochlea or labyrinth, and also cranial nerve palsy as a result from compression due to brain swelling, motor deficits, and also intellectual and behavioral disabilities. So, and then management and prognosis. So The aim of management is to sterilize the CSF and to maintain adequate cerebral and systemic perfusion. So the first thing we can do is to give antibiotic therapy. Even in children, when we suspect children with meningitis, antibiotic therapy should be given. Even in viral meningitis, we should give antibiotic therapy unless after we. Sorry. Okay. So the first treatment is antibiotic therapy. So these are antibiotic according to the organism. And if the children, even though we suspect a children with viral encephalitis, we should first treat the child with antibiotic therapy until we get the result of specific virus. Okay. Get it? Okay. And then after that, we can also do adjunctive therapy to support the primary treatment. We can give dexamethasone. It can be given together or before the first dose of antibiotic. So it is aimed to reduce the incidence of complications and also mortality. Okay, so apart from that, supportive measures should also be done to maintain the supportive measures should also be done. So we should do monitor temperature fast. Sorry, kejap ada orang datang kat bilik kejap. Okay, sorry. So supportive measure should be done to stabilize the cardiorespiratory and hemodynamic status of the patient. So we should monitor temperature, pulse, blood pressure, and respiration. And also we should give careful fluid balance in case of dehydration. And if the fontanelle is still open, note the head circumference of the baby daily, and also should do seizures chart, and also daily neurological assessment, and also observe the patient 24 hours after stopping therapy. And follow-up should also be done. So until when we should do the follow-up? Until the child shown to have normal development. It is usually until 4 years old. Okay, and then the prognosis of meningitis depends on age. The younger the patient, the worse the prognosis. And it also depends on duration of illness prior to antibiotic treatment. And it also depends on causative organism. For example, strep pneumonia, it is associated with worse outcome compared to other pathogens. And also presence of focal signs lead to worse diagnosis. What are the prevention that can be done to prevent meningitis? First is immunization. So routine immunization can be done against Haemophilus influenza and strep pneumonia and Neisseria meningitis. And chemoprophylaxis can also be given to household contact with the patient. It is to eradicate the carrier state and decrease transmission of infection. Okay, so that's it for meningitis. And a little bit about encephalitis. The definition of encephalitis is inflammation of the brain parenchyma with or without meningitis, and it is manifested by neurologic dysfunction. So if you want to distinguish between encephalitis and meningitis, in encephalitis there is abnormal brain function. So these are among the clinical presentations: fever, altered consciousness, seizure. And the etiology of encephalitis. it can be caused by infection or autoimmune reaction. And in some cases, the causes is unknown, but the most common causes is viral infection. Okay, so these are among the causative organisms that cause viral encephalitis. There are many viruses worldwide, but the most common are HSV, Japanese encephalitis, rabies, and Nipah. So the pathogenesis, how do virus get into CNS and cause encephalitis? So there are two ways of them getting into the CNS. First is by hematogenous spread. So they directly infect brain parenchyma, secondary to viremia. Okay. And then the second one is via retrograde axonal transport. So they go into the CNS through peripheral nerve. Okay, and then they lead to destruction of neural cells and inflammation of brain parenchyma. So what investigation can be done in case of encephalitis? Say lumbar puncture and then imaging of the brain. And then can also do serologic studies and PCR. Serologic studies to detect any antibodies against a specific virus, and also PCR. And the treatment, so management is supportive and usually require ICU admission to facilitate aggressive therapy for seizure, and airway monitoring and protection of increased intracranial pressure should also be done, and we should give antiviral towards the specific causative organisms, such as acyclovir for HSV and VSV, and then ganciclovir for CMV. So the prognosis of encephalitis, it has complications, and the complications can include paralysis or spasticity, cognitive impairment, weakness, ataxia, and recurring seizure. And mortality in encephalitis actually depends on the etiologic causes. So, for example, if encephalitis is due to rabies virus, it is usually very fatal. And Mycobacterium pneumonia also have a worse prognosis compared to other pathogens. So that's all from me, and these are my references.
Okay, then. Have you done, Amani?
Oh, yes, done. Okay, that's all from me.
Okay. So very good. Any questions? Any questions? Anyone? This is a very important topic. Meningitis and encephalitis is very, 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 very important because you will definitely see at least in a week, one or at least in a month, you'll see like 3 or 4 cases of meningitis and encephalitis. In units, you'll see maybe about the same number. So any questions? Actually, I've got questions. There's one very important aspect of meningitis that you miss, which is this complication of meningitis. You did mention about the prognosis, but the complication of meningitis is very important. Okay, so what are the complications of meningitis? How many?
I think the most common one is hearing loss. Hearing loss.
Besides that?
Besides that, cerebral edema, developmental delay, developmental problem.
Okay. Actually, when you answering questions, and as a doctor or as a medical student, try to answer in a structure. You have to have some form of structure when you answer questions. For example, my question, what is the complication? Then you can answer. Complication can be divided into like short term, medium term, or long term. Or complication can be divided into functional or anatomical or structural, things like that. So that you won't miss lah. Usually the way we present complication for meningitis is short term, medium term, and long term. So what is the short term? What are the short term complication of meningitis? Because the thing that you've mentioned is actually more to like longer term. These complication we only see after follow up, not during the acute treatment. Cerebral edema, you do get cerebral edema, but actually it's not that common. There are commoner complication. What are they? Do you know any? Or anyone got any ideas?
Maybe multiple organ failure.
Why? Why is that?
Due to bilateral hemorrhage, hemorrhage in adrenal gland, hypotension.
Okay, that's more if the patient presented with sepsis, kan? Usually patient presented with meningitis, you have to determine whether is this a meningitis or this meningococcal septicemia, kan? Okay, these are the two yang very important tau. Patient datang dengan meningitis or meningococcal septicemia. Meningococcal is meningococcal lah. Is Neisseria meningitidis infection, sepsis. So that leads to sepsis lah, severe sepsis, and usually die lah. But when we talk about meningitis, most common organism is actually strep pneumonia and also Haemophilus influenza. So we they actually rarely presented with systemic symptoms unless or severe bacteremia leads to sepsis, unless if they came late. But most of the time they came quite early because of they presented with altered behavior, altered conscious level, also seizure, kan? Actually the more common acute complications, important acute complications are such as subdural collection. They can get subdural empyema. They can get cerebral edema. They do get cerebral edema. The other common complication is actually SIADH. They can get SIADH. That's why you have to be very careful with fluid. Patient with meningitis or anything to the brain, insult to the brain, you have to be careful with the fluids because your pituitary is quite sensitive, especially your posterior pituitary. So your ADH can be affected by meningitis. That's why you have to be careful with your fluids. Okay, most of the time we don't give like full maintenance for patient with meningitis. We give like 2/3 maintenance, anticipating for SIDH. Okay, I said tu je kot. Any other questions? If not, then we can proceed with the next one. So read around there. Read around complication of meningitis, because this definitely will come in your exams, because it's very famous exam, very glamour exams. Exam questions on meningitis. Usually meningitis we will ask about the complication. Okay. And try to read around. I'm not going to tell you, but why is hearing loss? It's very prominent in meningitis. What makes the 8th nerve very very vulnerable to the effect of meningitis? It's very interesting. Have read about that. And what is the role of steroid in meningitis treatment? Okay lah, boleh proceed dengan febrile seizure.
Assalamualaikum warahmatullahi wabarakatuh. My name is Asma binti Anwar, and I'll be presenting about febrile seizures. So this is my outline for this presentation. So firstly, we need to know why is it important for us to learn about febrile seizure. So febrile seizure is the most common form of childhood seizure. it is considered benign and self-limiting. However, febrile seizure is considered a terrifying event for most parents, and this is one of the common cause for hospital admission for children. So what is meant by febrile seizure? It is a seizure occurring in association with fever, which is more than 38 degrees Celsius. It occurs between 3 months and 6 years of age with no evidence of intracranial pathology or metabolic derangement. So in general, febrile seizure is a diagnosis of exclusion, and I'll be explaining more later in my presentation. So for the epidemiology of febrile seizure, it occurs in about 3 to 4% of children. The earlier the age of occurrence, the higher the risk of recurrence. And there is genetic predisposition with a 10% risk in children if they have first degree relatives with febrile seizure. In Malaysia, according to a research done in 1994, boys are more prone to get febrile seizure compared to girls, and the incidence is the highest in 6 to find the recent data. However, despite that, this is one of the common cause for hospital admission, there is still little research of epidemiology in Malaysia. So moving on to the classification and clinical features, febrile seizure can be classified into two, and they are being classified according to the clinical features. So firstly is simple febrile seizure. It usually lasts shorter than complex, which is less than 15 minutes. While for complex seizure, it is more than 15 minutes. For the nature, in simple febrile seizure, it is a generalized tonic-clonic seizure. So it affects the whole body. And as you can see in the picture, in the tonic phase, the muscles become tense and rigid, while in the clonic phase, the muscles relax. In the complex febrile seizure, it is a focal, meaning that it usually affects specific body parts. In terms of recurrence, there would be no recurrence in 24 hours for simple, while in the complex, there would be multiple seizures in 24 hours. So for the post-ictal gestures, there would be none in simple febrile seizure, and there would be post-ictal gestures in complex febrile seizure, such as Todd's paralysis. So Todd's paralysis is a paralysis in the involved limbs after the seizure. So what happens if the seizure is lasts for more than 15 minutes and lasts longer than 30 minutes? So it is considered as febrile status epilepticus. And this is very important as febrile status epilepticus is a medical emergency, and it is characterized by either continuous or intermittent seizure without neurology recovery. So if the seizure, I would say more than 20 minutes, treatment should be initiated earlier by giving anticonvulsant, as it is a medical emergency. So for the complications of febrile seizure, there would be two. Firstly is epilepsy, and secondly is the recurrence of febrile seizure. And there is risk factors. There are risk factors for both complications. So for epilepsy, the risk factors are neurodevelopmental abnormality, such as cerebral palsy, which will be explained later in the seminar, complex febrile seizures, and family history of epilepsy. And for the recurrence of febrile seizure, a child with the risk factors are for having family history of febrile seizures, and when the child is younger, which is less than 18 months, and if the child has low degree of fever during the first febrile convulsion, and also a brief duration between the onset of fever and seizure, which is less than 1 hour. So for the pathophysiology of febrile seizure, the exact reason why febrile seizure occur is still unknown until now, but there is some possible explanation on why this happens. So firstly, majority of the children with febrile seizure, the seizure usually starts when the body temperature start to rise rapidly. So as we all know that fever is like activating our immune response. So when there is elevated temperature, it also impacts the ion channels, and this will increase the excitability and synchronization of the neurons. So this hyper excitation and the continuous firing of neuron eventually will lead to the occurrence of febrile seizure. So for the etiology of seizures, as I've mentioned earlier, febrile seizure is a diagnosis of exclusion. So it is mandatory to exclude all the underlying etiology of seizures in child presenting with fever and seizure before making the diagnosis of febrile seizure. And seizure can be due to many reasons. Like firstly, like infection, and usually is viral infection, like meningitis, encephalitis, urinary tract infection. And for the viral infection, usually it is more commonly by human herpes virus 6 infection. And secondly, it can also be due to trauma, metabolic conditions such as hypoglycemia, hypo or hyponatremia, and also other causes such as poisons, toxins, drugs, and hypoxic ischemic insult. Moving on to the management of febrile seizure, this is a summary table for the management, but I would like to emphasize here, the mainstay for the management is to identify the source of fever and also to provide parental education. So in this slide, there will be two parts, which is the management at home and the management at the hospital. So when a child when the child is having the first episode of the febrile seizure, parents should stay calm and don't panic. And most importantly is for the parents to take note of time on onset, to know the duration, to classify the type of febrile seizure, and then they can lay the child on the lateral side, as you can see in the picture. This is the recovery position, and also they can tap it sponging and remove the closest to lower the temperature of their child. And if there is second attack, they should go to the hospital. Most children do not require any treatment, and not all of them need to be admitted. So these are the main reasons for why the child should be admitted. So firstly is to exclude intracranial pathology, especially infections. And secondly, if the parents are having fear of recurrent seizures. Thirdly is to investigate and treat the cause of fever besides meningitis or encephalitis. And fourthly is to allay parental anxiety, especially if the parents are staying far from the hospital. So how did they manage the children with febrile seizure at the hospital? So antipyretics can be given as an act of a comfort measure. So I would like to emphasize here that antipyretics does not reduce the recurrence of seizure. It just are comforting to lower down the temperature of the child. And also rectal diazepam can be given. Rectal diazepam need to be given, but it is only to help to reduce the recurrence, not to eliminate the recurrence of the seizure. So for instance, if the child had already there's no episode of febrile seizure at the hospital and they are already going back to their home. So parents should be prescribed with fractal diazepam, and they should also be taught on how to administer in case there is a recurrence of the seizure.
Sorry, tak dengar suara.
Sorry. Okay, continuing from the investigations. Sekejap, ada orang datang. Sorry for the interruption. So for the investigation, firstly, we can make full blood count. If there is case of infection, they can notice there's a leukocytosis. And secondly, for blood urea serum electrolytes to rule out any electrolyte imbalance such as hypo or hypernatremia. Thirdly is random blood glucose to rule out hypoglycemia. Blood culture to identify causative organism. Urinalysis to rule out urinary tract infection, and also lumbar puncture to rule out meningitis and encephalitis. So in case of lumbar puncture investigation, it must be done if there is any signs and symptoms suggestive of intracranial infection, and also should strongly be considered in children less than 12 months because the sign and symptoms of meningitis is minimal or absent in this age group. So last but not least is the prognosis of febrile seizure. It has an excellent prognosis and there is certain percentage in the risk of recurrence, but most importantly is there will be no evidence of permanent neurological deficits following febrile seizures or even febrile status epilepticus. So a quick recap, febrile seizure is the most common cause of childhood seizure. It is a diagnosis of exclusion. It usually occurs in association with fever. The pathophysiology is still unknown, and the mainstay of management is to identify the source of fever and to provide parental education. And lastly is the prognosis is excellent. So these are all my references. That's all from me. Thank you.
Okay, good. Diam, diam. Okay, good presentation. Any questions from anyone?
Are there like any complications from febrile seizures?
The epilepsy and the recurrence, those are the only complications.
Oh, okay. Thank you.
Is it really complication of is it really epilepsy a complication of febrile seizure, or is it actually it's actually epilepsy rather than febrile seizure? I mean, rather than, when we say complication, is the direct effect of the disease that leads to future complication kan. Tapi I think epilepsy and febrile seizure is two different diagnoses, right? So in your reference memang dia kata complication of febrile seizure is epilepsy
Yes, doktor.
You guna apa? Up to date ke apa?
Nelson.
Okay. Actually, I want to look at your, can you show us the slides, risk factor slides?
Okay. Doctor, the reference is from PITS protocol.
Sorry.
The reference for complication is from pediatrics protocol.
I think I have to, I'll back to default lah. Tapi yes, it's ni risk factor. Can you open the slides risk factor?
You can, doctor.
Oh yes, ni risk factor. Okay. Okay, see the risk factor of epilepsy is neurodevelopmental abnormality kan. Actually, because epilepsy is a diagnosis of exclusion, we don't actually diagnose. You guys can hear me well, right?
Yes.
Okay, because line macam tak bercomis. We can actually diagnose febrile seizure in a child with abnormal brain. Child with cerebral palsy. We don't actually diagnose febrile seizure in epilepsy children, or in a child with developmental delay, or in a child with very positive, strong family history of epilepsy. We don't actually diagnose that because febrile seizure is diagnosis for exclusion. So it's a diagnosis of seizure at the onset of fever. Usually it's seizure with fever. With a background of normal child, normal child. So when we want to diagnose a child with febrile seizure, we have to make sure that the child has no developmental concern, there's no problem with there's no strong families of epilepsy, there's no atypical features, there's no focal sign, there's no atypical features, and besides that there's no neurocutaneous stigmata. So only these are normal, then only you can say this is a febrile seizure. Because febrile seizure is a normal child. Normal child just happen they got seizure because of fever. Understand tak? You guys get me, right? You guys get me, right?
Yes.
Yes.
So okay. So kalau it's a child, memang background dia contoh child with hydrocephalus kan, memang born pram, severe pram with IVH, and then complicated with hydrocephalus, and then come with seizure. You cannot diagnose febrile seizure. Faham tak? Atau you've got a child, datang memang the child memang kita tahu dia ada port wine stain kan, very obvious port wine stain on the face, datang dengan febrile seizure, then you cannot say this is febrile seizure. Atau a child came, memang bila you examine nampak memang ada multiple cafe au lait spot, then febrile seizure should not be your first diagnosis. Okay. Kan? And then you mentioned when you want to diagnose febrile seizure, the main thing is actually to exclude everything else kan. So how long would you take to actually exclude everything else? Do you really exclude? Do you really need to exclude everything, or do you what type of what diagnosis you should actually exclude before you can meningitis lagi?
Encephalitis.
Encephalitis, okay lagi?
This is what I found in hypoglycemia.
Hypoglycemia. Okay, good. So in general, before you diagnose meningitis, febrile seizure, kan, you have to rule out because it's actually very difficult to rule out meningitis. Okay, it's very difficult. So you have to have like evidence from examinations, and then from the history, then you can actually there'll be like you can get some idea that this might not be meningitis. Tapi more important to exclude is actually the metabolic causes, especially hypoglycemia, the reversible causes of seizure. Hypoglycemia first, and then electrolyte imbalance, then possible epilepsy syndrome. I mean from the history or from the physical examination. You faham kan? Then only after all that, because all this can be done in a short time. Then if everything is negative, then you can actually you can be confident to actually diagnose febrile seizure. Because if you take too long, you may miss meningitis, so you may delay antibiotic. Faham tak? Faham kan?
Understood.
Okay, good. So any other questions? Okay, remember, febrile seizure can only be diagnosed in a normal child. Okay, not in a child with any concern, especially neurological concern. Okay, to take home point untuk febrile seizure lah. Lagi satu I think I may misunderstand you, or maybe there's something wrong with the slides. You've mentioned about focal seizure, kan? How do you define focal seizure just now?
Affect specific body parts. Affect specific brain parts.
Okay. That's true. I mean that's correct. In terms of pathophysiology lah. Pathologically is a seizure that due to electrical discharge at a specific focus, kan. Tapi actually focal seizure is a seizure that did not affect your conscious level. That is focal seizure. You've got focal with secondary generalization. Tapi when you say focal seizure, the difference between focal and general seizure is conscious level. So general seizure is seizure that has loss of conscious level. So there's two type of general seizure. One is absence, the other one is GTC lah. Ataupun kita panggil grand mal ataupun GTC lah. Tonic-clonic. So typically, okay, febrile seizure, they will present with generalized seizure, which is either absence, they can present with absence, they can present with absence or GTC. Other than that, all are considered a complex seizure, because other than that are considered focal seizure, because they have there's no loss of there's no loss of conscious level. Okay, faham kan? You okay ke?
Okay, thank you, Doctor.
Okay, boleh sambung lah. Macam lambat dah. Okay.
Boleh dengar ke suara?
Dengar.
Boleh.
Assalamualaikum warahmatullahi wabarakatuh, and a very good evening to our supervisor, Dr. Alwi, and my fellow friends. So I will continue on with childhood epilepsy. So here is the overview of my presentation. I will start with definition, followed by epidemiology, classification, etiology, investigation, management, and epilepsy syndrome. So to start off, according to the pediatric protocol, epilepsy is defined as a chronic neurological disorder characterized by recurrent unprovoked seizure. As you have here before, seizure for epilepsy is a recurrent unprovoked seizure. Practically, it's defined as at least 2 unprovoked seizures occurring more than 24 hours apart. 1 unprovoked seizure and a probability of further similar The general recurrence is at least 50% after 2 unprovoked seizures occurring over the next 10 years. And the diagnosis of epilepsy syndrome, which I will tell you about at the last part of my presentation. So to remind you back, a seizure is a clinical event in which there is a sudden disturbance of neurological function caused by an abnormal or excessive neuronal discharge. So next, the epidemiology. According to a study, epilepsy is one of the most common chronic neurological conditions in children, and it affects 0.5% to 1% during the childhood. As this study was conducted in the United States, so it may or may not represent the worldwide. So the classification of epilepsy by the International League Against Epilepsy in 2017, it has categorized the epilepsy into 4 major groups, which are generalized, focused, combined, and unknown epilepsy. So generalized can further divided into small groups such as absence epilepsy or myoclonic, chronic or atonic, which I will further explain in the presentation. So focal epilepsy, we can divide it into which it will affect the awareness or not, remain aware. So the first type of epilepsy is generalized epilepsy. The patient will always have a loss of consciousness or awareness. There's no warning, and it happens in the brain symmetrically in both hemispheres. So the first type of generalized epilepsy is the absence seizure, which also known as petit mal, which doctor has mentioned just before. The patient will have loss of awareness and a vacant expression for less than 10 seconds, just like in the picture here I have put. And he or she will return abruptly to normal and continue as though nothing had happened. There are no motor manifestations, and the patient do not realize that they have had an attack or not. It may go on to develop into generalized convulsive seizures. The next one is tonic-clonic seizures, also known as grand mal. This type of seizure under the generalized epilepsy, there's no warning, and it can be divided into a few phases, which are tonic phases, clonic phases, and post-ictal phases. I'm sure it is very familiar, as Asma just mentioned just now. What happened during the episode of epilepsy is initial tonic stiffening is followed by the clonic phase with synchronous jerking of the limbs. The eyes remain open and the tongue is often hidden. There may be incontinence of urine and feces. After some time, a period of fractive unresponsiveness is followed by gradual return of awareness, and the patient will be confused and drowsy, lasting for about 15 to an hour or longer. Under the generalized epilepsy, also the myoclonic, tonic, and atonic. For the myoclonic, it is a jerk or momentary brief contraction of a muscle group. It also can be seen physiologically in hiccups or in passing through state to sleep. I'm sure everyone has experienced this before. The next one is tonic, stiffening of the body and not followed by the jerking. It is a generalized increase in tone muscle. And the next one is atonic seizure, which is the sudden collapse with loss of muscle tone and consciousness. It's also known as drop effect. As you can see this style here, there we go. the head suddenly dropped, and then followed by like it happens suddenly. Atonic seizure is often combined with myoclonic jerk followed by a transient loss of muscle tone, causing the sudden fall. The next type of epilepsy is focal epilepsy, different from the generalized. Instead of it happens in both hemispheres. For focal, it is restricted to a limited part of the cortex or only one cerebral hemisphere. It can have aura. Aura is like a warning. It can be like a smell or auditory hallucination, a fear sensation. It's like it the patient feeling the thing is coming. Or it can also have motor features and loss of awareness. For focal seizure with aura, the nature of the aura helps to localize the seizure focus. It can be from temporal, frontal, or occipital. Different area will manifest into different behavior or features. If temporal, the patient might have altered perception, or nausea, vertigo. For frontal, the patient will have conjugate gaze, and for occipital, it will affect the visual. For focal motor seizure, this type of seizure is originated within the motor cortex, and the jerking will typically start from one side and sometimes spread to involve the other side. It is known as Jacksonian march. And the last one is the focal seizure with altered awareness. It usually arises from temporal lobe, 60%, or the frontal lobe. Visiting aura followed by a period of complete or partial loss of awareness, 1 to 2 minutes, and accompanied by speech arrest, and often by automatism. What is meant by automatism? It is a semi-purposeful stereotype motion, like such as lip smacking, dystonic limb posturing, or a much more complex motor behavior, such as walking in circles or undressing. And this attack may be followed by post-ictal confusion, or may develop into bilateral clonic seizure. The etiology of epilepsy can be many, such as genetic, can be genetic, structural, and metabolic, immune, infectious, or unknown. Mostly epilepsy, the etiology is unknown. So how to investigate epilepsy? First, we must do the blood test, the routine blood test, to recognize the etiology of the seizure, to identify the infection, allergy, or any abnormalities, to prescribe any anti-epileptic drug if necessary. ECG might wanted to be done in most patients following an episode of loss of consciousness to check whether the patient has any heart condition. If the patient is suspected to have an epilepsy, EEG, electroencephalogram, must indicated. This is to identify a background of the epilepsy, and the findings might suggest the underlying structural abnormalities. For further investigation, imaging studies can be done either structurally or functionally. Structurally, structural scan is MRI or CT scan. It is indicated if there are neurological signs between seizures. This type of scan are not required routinely for childhood generalized epilepsy. For functional scans such as PET or SPECT, it can detect areas of abnormal metabolism suggestive of focal seizure. This can be used alongside the psychological testing, including memory assessment, to minimize the risk of post-operative impairment. Other investigation also can be done, such as metabolic investigation. This might we want to do it if there is any developmental regression or the seizure are related to fits or fast. Genetic studies also can be done as the certain type of epilepsy syndrome are due to genetic deletion. For management, we always have to begin with the explanation and advice to help adjustment to the condition. And we also need to provide the education and continuing advice on lifestyle issues for the patient and patient's family. The school needs to be aware of this health condition, and teachers must be advised on management of seizure if there's an episode at the school. This is the suggested drug for to manage the epilepsy. For generalized seizure tonic-clonic, the first line is valproate, carbamazepine, and the second line is lamotrigine and topiramate. For the absence seizure, valproate and ethosuximide. The second line is the lamotrigine. And for myoclonic seizure, the first line is valproate, and the second line is lamotrigine. For focal seizure, the first line is carbamazepine, valproate, and the second line is topiramate, levetiracetam, carbazepine, gabapentin, tiagabine, and vigabatrin. I'm sure all of you have learned this before, and you might want to recheck on our pharmacology. There are also other treatment options to manage epilepsy, such as ketogenic diet. This might be helpful, but the mechanism of action is poorly understood. If you do not know what is ketogenic diet, it is a high fat and protein with less carbohydrate. We also can do the vagus nerve stimulation. It is delivered by externally programmable stimulation of a wire implanted around vagal nerve, and it may possibly be useful. And last one is surgery. Surgery can be done on the patient. Only for those the clinical seizure are well localized, which is the EEG and the EEG, MRI, and the functional imaging findings is good. So we come to the last part of my presentation. This is some of the epilepsy syndrome which I've arranged according to the age group. So the first one is West syndrome, also known as infantile spasm. Usually happens for the baby around the age of 4 to 6 months or infant. The pattern is violent spasm of the head, trunk, and limbs, followed by extension of hands. Usually, infantile spasm should go away by 4 years old, but mostly it will develop into other types of seizure condition in childhood or as an adult. 1 in 5 will have Lennox-Gastaut syndrome. Yeah, the second one. So the second one is Lennox-Gastaut syndrome. Usually happens for the patient in the age of 1 to 3 years old. The seizure type is multiple seizure types, mostly drop attacks, tonic, and atypical absences. The patient will have a neurodevelopmental regression and behavioral disorder. So due to this, the prognosis is poor. It is a complex, rare, and severe type of childhood onset epilepsy. It may persist into adulthood. The third one is childhood absence epilepsy, usually happen between 4 to 12 years old. It is characterized by recurrent seizure. It is basically about the same as absence epilepsy. In generalized epilepsy, I've explained just now. The child has no recall, and developmental is normal, but it can interfere schooling as it will interfere with the social life. The next one is benign epilepsy with central temporal spike back. It usually happen in between the age group of 4 to 10 years old, and the pattern is a tonic seizure, and it happens in the sleep, or simple focal seizure with awareness of abnormal feeling in tongue and distortion of the face. It is a common syndrome affecting 15% of all epilepsy in children. The next one is early onset benign childhood occipital epilepsy, Panayotoulos type. This type of syndrome occurs between 1 to 14 years old. It is a rare type. For the younger children, the pattern is periods of unresponsiveness, high deviation, vomiting, and autonomic features. For the older children, headache and visual disturbances, including distortion of images and hallucination. And last but not least is juvenile myoclonic epilepsy. It happens in the adolescence to the adulthood. This is the most common generalized epilepsy in the childhood. It can be myoclonic seizure, but it can also be generalized tonic-clonic and absent shortly after waking. The typical history is that the patient might throwing conflict or ring about in the morning as the myoclonus occurs at this time. And the learning will not be disturbed. And this is my references. That's all.
Okay, good, very good. Any questions on epilepsy? No, ajak kakak. Sorry. Any questions?
Betul, saya ada soalan.
Tanyalah, tanya presenter.
Okay, soalan saya ialah in order to differentiate which type of seizure, do we just depend on clinical presentation only, or is it mandatory to do EEG as well? Because different seizure and different treatment. That's my second one. So how?
The question is how to differentiate different types of seizure, epilepsy, is it?
Do we just depend on clinical presentation or do EEG as well?
From what I've researched on, to differentiate the difference between the epilepsy is basically on the clinical presentation. And the first thing, the diagnosis in the book said we might want to have a video. It means that we need to know how the patient, how the child is, how does it happen? Because different type of seizure or epilepsy will manifest into different movement or
Ajak abang lah, ajak kakak.
behavior. Like absence, the patient will have loss of awareness.
Maya tak makan lah.
Different from the tonic. We will go into state like this, tonic phase and chronic phase. And what I can say is mostly it's based on the clinical features. How the guardian explained to us and like that. I hope that answers your question.
Okay, thank you.
Okay, that's very good questions actually. So basically will be to start the anti-epileptic kan. It mainly depends it depends on the clinical lah. That's why history is very important, because from the history you can decide whether this is generalized or this is focal, and is actually sufficient for you to decide on the type of anti-epileptic. However, okay, in some condition, okay, you may need to start some specific anti-epileptic that will work for that particular epileptic syndrome. For example, you've got a child kan, a young child with infantile spasm that you suspect infantile spasm. Then maybe baby 1 month old, 2 months old presented with drop attack kan, presented with looks like myoclonus or drop attack. Then this category of infant, then you may think this might be infantile spasm or West syndrome. Then EEG is indicated because you need a specific diagnosis. Once you confirm by EEG, hips, arrhythmias, and then you confirm this is infantile spasm, then you need to start methylpred, high dose methylpred ASAP. If not, you lost the child, because infantile spasm is very poor prognosis. Okay, because most of them will develop into West syndrome, and most of West syndrome will develop into Lennox-Gastaut. And this is the worst epilepsy syndrome lah. And then and also, for example, you've got a child kan, and then you've got a child who got the clinical features of tuberous sclerosis. Then also this type of children also you have to do EEG, because you want to make sure this is not infantile spasm or West syndrome, because you may need to set specific anti-epileptic such as vigabatrin rather than start epilim or lamotrigine or topiramide, which most likely will not work, because this is a very severe form of epilepsy where you need to start things like vigabatrin or methylpred. Okay, contoh itulah basically. Okay, faham kan? So it's good to have you need to get a very good history lah. You need a very good history to diagnose epilepsy, and supported with EEG, but EEG is not readily available, because to interpret and to perform EEG is difficult. So usually we depends on the history lah. Okay, any questions? Any other questions? Okay, kalau tak ada boleh proceed dengan next one lah, last kan.
Ada lagi 2, doktor.
Ada lagi 2? Banyak ke? Boleh habis by 10 ke? Saya ingat ada 4 je, alamak. Okay lah, you guys nak sampai habis ke atau nak sampai pukul 10?
Sampai habis.
Okay lah, okay. Then be quick lah, sorry. I thought ada 4 je. Okay.
Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So tonight I will explain about muscular dystrophy. Okay, this is my outline of presentation. So firstly, I will explain about the muscular dystrophy generally. Then I will explain about the most common one of the muscular dystrophy, which is Duchenne muscular dystrophy. Okay, so muscular dystrophy means that muscular is muscle. So dystrophy means bad nourished. So it means that muscle are poorly nourished because of the degeneration and cause the muscle weakness. And the changes occur in the muscle itself, but not at the nerve and the neuromuscular junction. So it is distinguished from other causes of the muscle weakness that result from the nerve damage. So by definition, muscular dystrophy is a group of the genetic muscular disorder. So it caused by the genetic mutation and it can be inherited. So it get characterized by the progressive myofiber degeneration, and muscle will gradually replaced by the fibrotic tissue. So as it is a progressive muscle disorder, over time, muscle weakness decrease mobility, making the everyday life of the patient difficult. Okay. So there are many kind and type of the muscle dystrophy, and each type affecting specific muscle group with sign and symptom that appear at different age group, and also it vary in severity. So for the type, the Duchenne and Becker type, they appear the weakness first at the upper arm and also upper leg. And then for the Emery and Dreyfus, for the Emery, they appear at the arm, leg, heart and joint. And then for the limb girdle, they appear first at the upper arm and upper leg. For the facioscapulohumeral, they appear at the face, shoulder, and upper arm first. So for the distal, at the feet, hand, leg, and then lower arm. And for the oculopharyngeal, they appear at the eyes and throat. Okay, so the etiology, as I said earlier, that it caused by the gene mutation. So the etiology is abnormality in the genetic code that for the specific muscle protein. So they can be classified into the inheritance patterns, which are autosomal dominant, sex-linked, and also autosomal recessive. So for the sex-linked, sex-linked are Becker and Duchenne. For the autosomal recessive are Limburger form, and other are autosomal dominant. So these are the protein at the muscle. So for the dystrophin, if there is a genetic mutation in the dystrophin, it can cause Duchenne and Becker muscular dystrophy. So Duchenne muscular dystrophy and Becker muscular dystrophy are called dystrophinopathies. And as you can see here, there is also the other protein that also cause other muscular dystrophy. So other gene mutation that responsible for other muscular dystrophy also involved with the protein complex with the dystrophin protein. So it can cause a lot of the same symptom with dystrophinopathies. So for the dystrophinopathies, so as I said earlier, it divided by two, which is Duchenne muscular dystrophy and Becker muscular dystrophy. For Duchenne muscular dystrophy, it's a total loss of the dystrophin. So
planning ni perancangan yang panjang lah. Basically macam kita orang ni ni pada pendapat saya sendirilah. Saya rasa kita orang baru start macam nampak aktif sejak saya masuk Kuantan ni, sejak masuk degree ni. Saya rasa yang nurse ni baru start aktif pada tahun yang lepas. So baru nampak ada plan-plan lah. So antara plan yang dari
Okay, I will continue. Okay. For the Duchenne muscular dystrophy, it is the most common muscular dystrophy. Okay. So it is caused by the loss of the dystrophin that result no protein at all. So it more severe and the symptom present at the age of 5. And for the Becker muscular dystrophy, it caused by the misshapen of the dystrophin. So it a milder form of the Duchenne muscular dystrophy. So the symptom present at the age of 10 to 20. Okay. And the Becker is the second most common. Okay, so the thing that I want to enlighten today is Duchenne muscular dystrophy. So Duchenne muscular dystrophy, most common muscular dystrophy, and also one of the most common genetic disorder in the childhood. So it affected approximately 1 in 3,500 male infants worldwide. So the Duchenne muscular dystrophy is X-linked recessive disorder. And it also can caused by the spontaneous gene mutation about 1/3 cases. So this gene mutation resulting in deletion of the short arm of the X chromosome at the XP21 site that code for the dystrophin protein. So as you can see at this, so if the male have one X and one Y, while the female have two X. So this means that muscular dystrophy are more common in boys because they have one copy of dystrophin gene. So if it defective, it is the only one that available for the muscle cell. But for girl, if they defective in gene, so they have another one. So woman can be a carrier and asymptomatic. So so if the carrier mother will give the half of their future son to get the mutation, and half of your future doctor will be a carrier. So for the dystrophin protein, why dystrophin protein is important? Because it connect the cytoskeleton of the muscle fiber to the surrounding extracellular matrix through the muscle membrane. Okay, so what happened in Duchenne muscular dystrophy is there is loss total of the dystrophin. So when absent, it will lead to the myofibril membrane instability, as you can see in this picture. So the muscle membrane will damage. So after it damage, it will permit the pathology entry of the extracellular calcium, and then it will release the creatine kinase into the blood circulation. On the other hand, the inflammatory mediators in the dystrophic muscle also may increase the inducible nitric oxide synthase, so which result in excess calcium ion that lead to the muscle proteolysis. So in this picture, after the muscle proteolysis and cause cell death, muscle will be regenerate. But after it progressive, the fibrotic tissue and fat will cover the muscle, the remaining muscle. For the clinical manifestation, the infant boys, they rarely symptomatic in the early infancy, but they can have history of the poor head control and also mild slowness in attaining the motor milestone. For the clinical onset, usually it can occur during the 2 or 3 years of age, although the age of diagnosis usually at 5, but the symptom can occur early. So the patient might have the delayed motor development. So the patient have taking longer to learn to see, to stand or walk. And then they also usually do not begin to walk until the age of 18 months or later. They also might have cognitive and intellectual impairment. So the affected boys tend to be slower and clumsier than other peers. And they have the muscle weakness that got worse over time and delayed speech and language development. So in this picture, it shows that the child have the muscle weakness. So it caused the foot drop or tip to contracture, and then it goes way back here, and then it caused poor balance, and the child might fall often. And early sign for the Duchenne muscular dystrophy is waddling gait. Waddling gait, weight-based gait, toe walking, and also it's known as a duck-like walk. So it caused by the weakness in the hip muscle, which are gluteus maximus and gluteus medius muscle, and the patient inability to support a single leg stand. So the patient walk, the child leans the body to the other side to balance the center of the gravity. Okay. Next is lumbar lordosis. It caused by the hip extensor weakness. So you can see the exaggerated lumbar curve here. So hip extensor weakness resulting in forward tip of the pelvis to hyperlordosis of the spine to maintain the posture. And then after that, the patient might seem to have walk on the tip toes, and it is easier for the patient to stay vertical with equinus foot position. So this is equinus foot position. So gradually, the child often observed to have increase in difficulty with the step taking, and then they also might have the frequent fall, and also they begin to having problem getting up from the sitting or supine position. So then the classical sign of the Duchenne muscular dystrophy are Gower sign, where the patient using hand to push on the leg to stand. So it caused by the weakness in child proximal hip muscle. So after that, another clinical presentation are pain in the calf with activity, and then progressive enlargement of the heart, which are dilated cardiomyopathy, because dystrophin also expressed in the heart muscle. So there is extensive fibrosis in the heart wall. And then there is enlarged calf muscle pseudohypertrophy. This pseudohypertrophy because of the fat and fibrous tissue, and macroglossia, which are large tongue. So the upper extremity involvement manifests in the later stage, and most children need to use wheelchair by the age of 20. And they also, most of them die of the respiratory complication by the age of 20. So you can see at the picture at 2 years, there is minimal or no symptom. At the 8 years, so there is lordosis. And for the 15 years, they need to use the wheelchair because of the severe deformities and contractures. For differential diagnosis, is the another muscular dystrophy, another type. The middle one is the Becker muscular dystrophy, and Limber-Girdle muscular dystrophy, Emery-Dreifuss muscular dystrophy, and also differential diagnosis might dilated cardiomyopathy and spinal muscular atrophy. For the complication, patient might come with the scoliosis, which spine curve from side to side in S or C-shaped. So the complication might shorten the lifespan, as patient might have cardiopulmonary failure. So decreased heart function and cardiomyopathy lead to heart failure, and weak diaphragm lead to respiratory failure. And patient also might confine to the wheelchair dependence and have a contracture. And patient usually also fall and cause fracture and osteoporosis. So for the prognosis, patient with the Duchenne muscular dystrophy, they may see improvement in the 3 and 6 years of age. Then it followed by the gradual and relentless deterioration. But before the age of the 12 years, most patients already lost of the ambulation, so they need to use wheelchair. And they also require the non-invasive ventilation by the late teenage year. So life expectancy is shortened, but survival in adulthood is now common because of the treatment with the glucocorticoid and also advance in the cardiac and pulmonary care. However, although there is also advances, survival beyond the third decade is also uncommon. Okay. For the diagnosis and investigation, so diagnosis is based on the clinical diagnosis, based on clinical examination, sign and symptom, family history, when we want to suspect the patient. So this is from the clinical presentation that I already presented earlier. So to confirm the diagnosis, we need to do the elevated creatine phosphokinase, because if the creatine phosphokinase is normal, so it is unlikely to be Duchenne muscular dystrophy and also Becker muscular dystrophy. So if the creatine phosphokinase is elevated, we need to do a genetic testing to confirm it. So if the genetic testing sometimes can be hard to detect, so we need to do a muscle biopsy by taking a small piece of the muscle for the examination under a microscope. So you can see here, the normal muscle and the affected muscle with child with the Duchenne muscular dystrophy. For the management, there is no known cure, but aim of the management are to manage the symptom and the complication. So patients are given steroid therapy to slow the pace of the disease and to delay motor disability. But the side effects are patient can have excessive weight gain. And patient also need to got supportive care such as physical therapy, bracing, proper wheelchair, and a treatment for the cardiopulmonary dysfunction, pulmonary infection, and counseling, as I will present after this. So they need supportive therapy to improve their quality of life. So the first one is rehabilitation, orthopedic intervention. So patient need to have the physical therapy to encourage the mobility and to prevent the risk of the contracture. Okay, so patient need to have to do the basic stretching exercise at the ankle, knees, hip. Then it may be needed to the wrist, hand, and neck, and then it need to do for the 4 to 6 times a week. Then patient need also to have exercise to avoid the disused muscle atrophy, immobility to avoid the excessive weight gain and social isolation. So there is also additional intervention such as patient can wear nut splint to have to got the circulation when they sleep, and then patient can also wear the long leg braces to walk, and patient also can wear the wrist or the hand splint to stretch wrist, and then patient also can stand by the power stand up motorized wheelchair. Okay. For the complication, which are scoliosis, we can reduce by maintaining a good sitting posture, by standing and ambulation, and by wearing a truncal brace. Next is for the cardiac management. So we need to monitor the patient for any cardiac complication. So by do a screening by electrocardiogram, electrocardiography, and MRI. For the patient with cardiomyopathy, we give them an angiotensin converting enzyme inhibitor or beta blocker. And for the respiratory management, we monitor the patient at the ambulatory stage when the patient is 5 to 6 years of age, and for monitor them yearly. And then for the non-ambulatory patient, at least for the 6 months. So if patient have the respiratory insufficiency, patient need to have non-invasive ventilatory support or elective tracheotomy. And if patient have the respiratory infection, patient can get the antibiotic therapy. And patient also need a psychological care. So there is need a routine assessment for patient and also family mental health. And for patient may also have need to advance planning and palliative care. So doctor may inform the patient of their long-term prognosis at their specific age. So because as the disease progress, patient might need hospice care, and patient also need to have the support group or organization any organization of the muscular dystrophy, so then they can be more educated about the complication, about the therapy and that. Okay, so this is the summary of the Duchenne muscular dystrophy. So as I said earlier, that usually it diagnosed at the age of the 5, and they confined to the wheelchair at the age of 20 and don't survive at their mid-20s. So these are the symptoms and also complication of Duchenne muscular dystrophy patient. Okay, this is my references. So that's all from me. Is there any question?
Anyone? Okay, that's very, very good slides. I'm really impressed with your slides. In fact, the earlier slides, the introduction summarized beautifully the type of dystrophy, muscular dystrophy. And you have to understand muscular dystrophy is a lower motor neuron problem. So neurological findings are actually lower motor findings. But confined to your motor unit, to your motor disorder lah, to your muscle. To the muscle. So it's actually degradation of the muscle rather than the nerve. Okay, it's a myopathy lah. It's sort like a myopathy. And then okay lah. In general, Duchenne is X-linked. And they rarely survive beyond 20s. Main complications is actually pulmonary complications. Some got heart rate complication, but mainly it's actually pulmonary complications. They've got very weak, towards the end of their life, they've got very weak respiratory muscles. That's why they need an IV lah. They need usually BiPAP, in the form of BiPAP. Because after, once the disease progress, the weakened respiratory muscles leads to CO2 retention, pulmonary hypertension, and subsequently respiratory arrest lah. Okay. Any questions? If not, then we can proceed to the last one. Later, can you guys share your slides? Because I know some of your slides are very good. Particularly, I really impressed with the slide. The Duchenne slides, the epilepsy slides, and the rest equally good, but particularly the epilepsy and Duchenne. Okay, next. Okay, ada soalan? Duchenne can come in your exams. We do have Duchennes. I'm not sure about your Ela, tapi I do have few patient Duchenne, and they always come in exams. One of the differential diagnosis is actually again SMA. Sometimes it's a bit difficult to differentiate Duchenne and SMA, especially SMA yang type 3, type 4 lah. Yang type 1, type 2 tu, type 0, type 1 biasanya by the time 2, 3 years old, dia memang dah tak ada dah. Tapi the late onset SMA sometimes are quite difficult to differentiate between with Duchenne. Okay, tak apa. Okay, so next. CP is a very big topic. Maybe you can like focus. I think just focus on spastic CP lah, rather than all this etiquette CP. Okay.
Okay. So, okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Nur Ainadia, and I'll be talking about cerebral palsy. And I'm the last presenter, so I'll try to be quick. And these are what I'll be talking about. Okay, so what is cerebral palsy? Cerebral refers to the cerebrum, so having to do with the brain, and palsy means any brain injury that results to a disorder of movement. So what is cerebral palsy? It's a group of disorders that affect a person's ability to move and maintain balance and posture. So it's usually due to a non-progressive lesion on the motor pathway in the developing brain of infants. So it is actually the most common motor disability in childhood. It is known also as a static disorder. What does that mean? It is permanent, but the disorder itself is not progressive. So CP is usually caused by the abnormal brain development or damage to the developing brain that affects the person's ability to control his or her muscles. So the range of CP in children, 1 to 5 or even 2 per 1,000 live births or children of a defined age range. And mostly the symptoms vary. And the prevalence actually hasn't changed for a long time, or long period. And in the US, about 1 in 323 children has been identified with CP. Okay, so there's many types of classification of CP. There's motor function, topographical distribution, gross motor function classification system. So first, this is one of the most common classification. First is statistic, where there's 70% of cases of CP are actually spastic. So it is basically the damage to the upper motor neuron, so the upper motor neuron lesion that affects the pyramidal and corticospinal pathway in the cerebral cortex. And that's what it causes stiff muscles, which is spasticity. And then we have dyskinetic, which and dyskinetic, ataxia, and mix, where mix is basically a mixture between three of those types. And they're less likely with 10% for each. Okay. The next classification is the topographical distribution, where they basically talks about the different parts of the body that is affected. And if you can see, spastic has hemiplegia, where basically like half of the body part is affected, and then diplegia mostly at the limbs, but the hand at the limbs, and then quadriplegia, where basically the whole part, 4 of the limbs are affected. And we have atherotonic, dystonic, and ataxic. The next type is the gross motor function classification system. So how they classify is, first, in level 1, you can walk without limitations. Level 2, you can walk with limitation. For example, you need help, like holding on the stairs. And then level 3 is you need adaptive assistance. So that's why you can see the child in the wheelchair or in the crutches. And then level 4 is usually where you're powered by mobility assistance, where you need sit supported. As you can see, they use the electric wheelchair. And lastly, level 5, where there's basically severe head and trunk control limitations. So you need self-mobility by powered wheelchair. As you can see, the child is wearing like a pinggang at the chair. Okay. Next, I'll be talking about the etiology, basically the causes. So the causes of CP is often multifactorial. Sometimes a specific cause is hard to establish, and in many cases, you cannot actually get a definitive cause. So in antenatal, usually in antenatal, the most common cause is the prematurity and low birth weight. Is usually associated with periventricular leukemia or even interventricular hemorrhage, and that's how it can lead to CP for cases in prematurity and low birth weight. Basically, it takes about 80% in CP. And then we have perinatal at 10% and postnatal at also 10%. And also, if you notice, the congenital infection. So the infection can usually cause initiation of preterm labor, and that's how it causes the CNS injury. And once it causes the CNS injury, you now have an underdeveloped fetal brain. So when the brain is underdeveloped, that's when the infant has inflammation and actually attract more inflammatory cytokines. And when there's more inflammatory cytokines, it leads to the periventricular leukemia and also thus CP. So those two important causes are usually what we should focus on in CP. Also with birth asphyxia, as it is also the most common for perinatal. Okay, next are the clinical features. So the clinical features for CP, usually it's how we do the developmental test in infants. So we usually can observe that from the docility and irritability. As you can see, they have abnormal motor development. So they can't lift their head or push their arms. They have poor feeding due to any slow feeding, gagging, vomiting. They have abnormal reflexes, abnormal muscle tone, and also asymmetric movement pattern. Okay, next, there are different symptoms in each type of cerebral palsy. However, since spastic is the most common with almost 70%. So one of the most symptom that you can see is seizure gait, you can see persistent primitive reflex, hypotonia, you have a positive Babinski sign, and yeah. And then there's different types, as I've mentioned about the topographical distribution, right? The hemiplegia, diplegia, and quadriplegia. Okay. And then this is an example of scissor gait. Okay, as you can see, the child can't really move and the legs are like crossing like scissors. So that's what scissor gait means because of the spasticity. Okay. And then this is basically the clinical manifestations.
Movement and coordination problems associated with cerebral palsy may include variations in muscle tone, such as being either too stiff or too floppy, stiff muscles and exaggerated reflexes, spasticity, stiff muscles with normal reflexes, rigidity, lack of muscle coordination, ataxia, tremors or involuntary movements, slow writhing movements, apoptosis, delays in reaching motor skill milestones, such as pushing up on arms, sitting up alone, or crawling, favoring one side of the body, such as reaching with only one hand or dragging a leg while crawling, difficulty walking, such as walking on toes, a crouched gait, a scissors-like gait, with knees crossing, a wide gait, or an asymmetrical gait, excessive drooling or problems with swallowing, difficulty with sucking or eating, delays in speech development or difficulty speaking, difficulty with precise motions, such as picking up a crayon or scissors or a spoon, seizures, brain abnormalities associated with cerebral palsy also contribute to other neurological problems. People with cerebral palsy may also have difficulty with vision and hearing, intellectual disabilities, seizures, abnormal touch or pain perceptions, oral diseases, mental health, psychiatric conditions, urinary incontinence.
Okay. Now I'll be talking about the differential diagnosis. Why differential diagnosis is important? Because CP is also a diagnosis of exclusion. So you can't directly diagnose CP, so you must exclude other diseases. So it should be differentiated with the progressive hereditary neurologic disorders and also disorders requiring any surgical or even neurologic treatment. So that's why if you can see from the neurological disorders, we should differentiate from the hereditary neurodegenerative diseases by milestone regression or Rett syndrome, even disorders of ataxia, because it's usually hard to distinguish. And then for ataxia telangiectasia, it can also have cutaneous or even ocular abnormalities. That's why it's also difficult to diagnose. Okay. And then how to diagnose, since I said it's not easy to detect early in life. So sometimes we do the developmental monitoring where you basically, where you basically go track the child's development, developmental screening if you see there's any developmental delays, or even do the developmental and medical evaluations where you try to diagnose a specific type of disorder. Okay. And then diagnosis of CP can also be challenging because since it's static and there's non-progressive, so the clinical findings still can change as the nervous system matures. Okay, so the diagnosis also involves a combination of finding. So that's why there's no specific or absolute test to help the diagnosis. You usually do a test to basically work up a differential diagnosis, such as searching for the glucose level, the ammonia, or even, for example, testing for the thyroid stimulating hormone to rule out any thyroid abnormality, for example. However, the most important investigation in CP is just two, which is the brain MRI and EEG. So the brain MRI can detect and identify the structural lesions in the brain and also determine the cause of the lesion. And EEG is usually to rule out seizures. Okay. And how to manage? There's no curative treatment. However, we can try to improve the lives of the patient diagnosed with CP. So usually we go through the MDT, which is multidisciplinary multidisciplinary team approach, where you have many people in the community, such as the doctors, the parents, to help improve the lives of these patients. So basically, from the medical perspective, we can have regular assessment, making sure they're okay, or even giving some drugs, or even having surgery to correct any deformities they have at the brain or at their hands, or even have surgery to reduce the spasticity or even disabling their dystonic movement. So the psychiatrists, by psychiatry, we can have the psychologists who work with them, a social worker to talk with them if they have any problems, and try to provide an education from them. And also rehabilitation, we can have them go through physiotherapy, speech therapy, since we know they are known to have developmental delay. And then we can also ensure or teach how the parents should care them at home, or even prepare an employment plan for them when they reach adult, or even external aid. And the prognosis for CP, most children actually survive to adulthood. So the severe limitations in sucking or swallowing usually helped by the gastrostomy tube, decrease life expectancy. And also the goal is usually for the children to develop maximal independence within limits of their motor and associate deficits. So basically how we try to make the children be independent, even with their developmental delay, or even with their limited movement that they can do, and since it affects most of it, so we try to help them adapt with their condition. So in conclusion, cerebral palsy has many causes, and it usually presents in infancy, and it could also be spastic, dyskinetic, ataxic, or a mixed pattern. And these are my references, and that's the end.
Okay, any questions? Okay, so principle you have to understand, CP is a non-progressive lesion that occur on developing brain. Okay, so it has to be developing brain. Any lesion, any insult to developing brain can be it can be like trauma, it can be metabolic insults, it can be infection. So meningitis, encephalitis, all can cause CP. So CP is not a disease rather, but it's a complication of disease. And remember, even though it's non-progressive lesion, but the presentation is progressive. Faham kan? The lesion itself is not progressive, tapi the presentation is progressive. As the child grow and develop, then the clinical presentation will become worsen. And remember, CP is a motor disorder. Dia tak involve benda lain. However, in a child with like global, especially quadriplegia with global brain insults, it can affect dia punya other area. But it's not because of the CP, but because of the insults. CP itself is a motor punya disorder. Okay, faham? Ada soalan? Ada any questions?
Tak ada question, Doctor.
Okay, CP is very important. It's very common. So you have to understand how to differentiate between diplegia, spastic CP kan? Diplegia dengan quadriplegia and hemiplegia. So diplegia is CP that involve both upper limb and lower limb. Okay, diplegia bukan involve lower limb je. The diplegia involve both upper limb and lower limb. Tapi worse in the lower limb to diplegia. The upper limb can have function. Kalau quadriplegia, it involve both. Macam ni kan? Quadriplegia they involve both. Tapi worse on upper limb. Tapi lower limb pun ada. But there's no hand function. So the only difference, how to differentiate between diplegia and quadriplegia is quadriplegia has no hand function. Tapi diplegia they can have hand function. So just now you use the GMFCS kan? There are three three like three functional classification of CP. You can have GMFCS, you can have MACS, and also CFCS. So usually when we describe about CP, we will say this child has spastic quadriplegic CP with GMFCS level 5, MACS level 4, CFCS level 3. That's how you describe about patient CP. That is a better way so that we know how is the child functioning and how is the child performing. I mean in their daily activities. Okay, faham? Okay, any last questions before we end? Okay, kalau tak ada dah, kita tanggungan tasbih kafarah dan suratul As. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Doctor.
Thank you, Doctor.
Thank you, presenter.
Thank you, Doctor.